The primary indication for hemodynamic monitoring is the management of critically ill patients who demonstrate evidence of compromised cardiovascular function. As such, hemodynamic monitoring can be used for the diagnosis and treatment of life-threatening conditions such as shock, heart failure, pulmonary hypertension, complicated myocardial infarction, post-cardiac surgery, acute respiratory distress syndrome or ARDS, chest trauma, severe burn injury, and severe dehydration. Invasive hemodynamic monitoring requires the insertion of an arterial and intracardiac catheters. Measurements typically include systemic arterial pressure, central venous pressure, pulmonary artery pressure, as well as arterial and mixed venous blood gases and cardiac output. Once obtained, these measurements can be used to calculate a series of derived variables including oxygen delivery, cardiac index, stroke index, vascular resistance, and cardiac work, which in turn can be used to better define abnormalities in the cardiopulmonary function and ultimately guide therapeutic interventions. The outputs of the right and left ventricle are ultimately influenced by four main factors: heart rate, preload, contractility, and afterload. An individual's heart rate, which is simply the number of times the heart beats per minute, can vary considerably depending on the patient's age and body habitus, core temperature, level of activity, and even psychological state. Heart rates can range from 50 to 200 beats per minute in a normal, healthy adult. The preload, which is typically defined as the filling pressure of the ventricle at the end of ventricular diastole, is estimated by measuring the end diastolic pressures, or EDP. The amount of blood present in the ventricle at the end of ventricular diastole depends on the level of venous return and the compliance of the ventricle. Ultimately, preloads reflects the length of the ventricular muscle fibers and thus the ability of these fibers to generate the necessary tension in the next ventricular contraction. This is a basic principle of cardiovascular physiology, sometimes called the Frank-Starling mechanism or length-tension relationship. This principle states in most basic terms that the heart pumps what it receives. This relationship holds until one reaches relatively high ventricular volumes when the muscle fibers are overstretched and unable to generate the necessary tension to elicit a contraction that will adequately eject the required stroke volume. The end result at these higher ventricular volumes is ventricular dilation and failure. The right ventricular end diastolic pressures is typically used as an indicator of the right ventricular preload, and the left ventricular end diastolic pressures is used to estimate the left ventricular preload. Because both of these intracardiac pressures are difficult to measure in the critical care setting, clinicians rely on measurements of the right atrial or central venous pressure and pulmonary artery occlusion pressure, also known as PAOP, or in some instances, practical purposes is equivalent to the pulmonary capillary wedge pressure, or PCWP, to estimate the right ventricular end diastolic pressure, or RVEDP, and the left ventricular end diastolic pressure, or LVEDP, respectively. It is important to understand that CVP and PAOP, or the pulmonary artery occlusion pressure, can accurately reflect the RVEDP and LVEDP only when the former measurements are made at the end of ventricular diastole, and if there is no evidence of valve dysfunction because they are registering retrograde pressures in the right and left atria. Contractility, which is related to the force that the ventricle generates during each cardiac cycle, can be estimated using the ejection fraction, which is calculated as the ratio of the stroke volume to the ventricular end diastolic volume. For example, A 154-pound or 70-kilo adult male typically has a stroke volume of about 70 mLs and an end-diastolic volume of about 140 mLs. His ejection fraction would then be equal to 0.5, which is basically the 70 mLs divided by the 140 mLs. Alternatively, contractility can be estimated by calculating the slope of the ventricular pressure time interval during the initial period of contraction. This change in pressure relative to time is thought to be a practical way of estimating the force of ventricular muscle contraction. Afterload is usually defined as the impedance that the left and right ventricles must overcome to eject blood into the great vessels. Clinically, this impedance is better expressed as systemic and pulmonary vascular resistances. The systemic vascular resistance, or SVR, is used to describe the afterload that the left ventricle must overcome to eject the systemic circulation. The pulmonary vascular resistance, or PVR, reflects the afterload that the right ventricle must overcome to eject blood into the pulmonary circulation. Increases in afterload are generally associated with reductions in cardiac output, whereas decreases in afterload are associated with increases in cardiac output. For example, the systemic hypertension and pulmonary hypertension lead to increases in SVR and PVR respectively. In both cases, the cardiac output will be reduced. Administering a systemic vasodilator or a pulmonary vasodilator will reduce the SVR and PVR respectively and results in an increase in cardiac output. Clinicians who perform hemodynamic monitoring must understand the physical and technical factors that can influence intravascular measurements and thus determine the likelihood of obtaining meaningful data. The following sections will first describe how hemodynamic measurements are obtained, and then discuss how various pathophysiological events can alter pressure, volume, and flow tracings. Hemodynamic monitoring systems consist of equipment that detects small physiological signal or vascular pressure changes and converts them to electrical impulses, which can then be amplified and recorded on a computer monitor or strip chart recorder. The catheter transmits pressure changes within the vessel or cardiac chamber through a hollow plastic tubing filled with a heparinized solution of saline to a transducer, which converts these fluid pressure changes to a digital signal for display. Strain gauge pressure transducer uses an electrical circuit known as a Wheatstone bridge. The operating principle for this type of device is fairly straightforward. Fluid enters the dome portion of the transducer by the way of the fluid-filled plastic line. A diaphragm separates the fluid-filled compartment from the electronic portion of the transducer. Pressure transmitted to the fluid-filled dome portion of the transducer causes movement of the diaphragm, which alters the length of the wires of the Wheatstone bridge. Changes in the length of the wires results in changes in resistance to the current flow through the Wheatstone bridge. Thus, the pressure changes are directly proportional to the change in current flow through the circuit and inversely proportional to the resistance offered by the circuit. Fluid can exert pressure while it is in motion, or hydrodynamic pressure, or while at a standstill, or hydrostatic pressure. These pressures play integral roles when using hemodynamic monitoring systems. Two factors affect fluid-like systems. First, a dynamic pressure element, and number two, static pressure head. The dynamic pressure element is pressure applied to fluid inside the system by fluid outside the system. It has to do with catheter position in relation to the flow of the blood within the vessel. For example, for an arterial line placed in a radial artery, to accurately measure pressures that are the direct result of the work of the left heart, it must be placed with the end of the catheter facing the source of blood, or looking upstream toward the left ventricle. A pulmonary artery catheter, which measures pressure within the vessel, such as the pulmonary capillaries or the left heart chamber, must be placed so that the tip of the catheter is facing downstream of the flow of blood to estimate blood pressures filling the left side of the heart. Static pressure head refers to the pressure placed on the transducer as related to the tip of the catheter. To measure pressure accurately, the transducer must be at the same height or level as the catheter tip. If the catheter tip is higher than the transducer, the monitor will read higher than the actual pressure as a result of the fluid pushing downstream because of gravity from the catheter tip to the transducer. If the catheter tip is placed below the level of the transducer, the fluid will flow away from the transducer toward the catheter tip and produce a reading lower than the actual pressure. The degree of error is about 1.86 millimeters of mercury for each centimeter of distance from the reference point. This adjustment can be avoided by positioning the transducer at the level of the mid-thoracic line of the patient to measure CVP accurately. This is about 5 centimeters behind the sternal angle, or the angle of Lewis. Once the epistatic line, or the mid-thoracic line of the patient, has been determined, it is important to zero balance the transducer to this reference point. Zero balancing the transducer references the transducer to atmospheric pressure, which is usually read as 0 millimeters of mercury. Direct measurements of the systemic arterial pressure requires the insertion of a catheter into a peripheral artery, such as the radial, brachial, or femoral arteries. Note that the radial artery is the most commonly used site because of easy accessibility and because of collateral circulation to the hand from the ulnar artery. Either a percutaneous technique or a surgical cut-down technique can be used to insert the catheter. The percutaneous approach is most often used in the critical care setting. The surgical cut-down procedure is used when the percutaneous technique is unsuccessful. Distal ischemia should be suspected when pallor distal to the insertion site occurs, particularly if it is accompanied by pain and paresthesia in the affected limb. The most common cause of decreased perfusion is thrombus formation, which occludes the catheter tip. Other risk factors for acute distal ischemia include hypotension, severe peripheral vascular disease, and the use of vasopressor drugs. Fever in any patient with an intravascular line should alert the clinician to infectious complications. The catheter is removed if there is evidence of local infection or the presence of distal ischemia. Difficulty withdrawing blood or persistence of damp tracing should also alert the clinician to possible complications, such as the presence of air bubbles in the line or occlusion to the catheterized artery. Bleeding can occur if the line becomes disconnected or is improperly handled. Hemorrhage is a distinct possibility if the line is left open. Therefore, the clinician should stabilize the catheterized site by taping the patient's arm to a board and placing it above the bed linen for easy observation. Another common problem encountered with the insertion of arterial lines is hematoma formation, which can occur if bleeding occurs under the skin during or immediately after the catheterization procedure. Hematoma typically occurs more often when the catheter is placed through a large gauge needle. Catheter placed in the vena cava or right atria are generally called central venous lines. Although these lines are most often used to administer fluids, drugs, and nutritional solutions, they can also be used to monitor right heart pressures. During ventricular systole or atrial diastole, when the tricuspid valve is closed, the pressure measured at the right atrium or vena cava reflects the right atrial pressure. At the end of ventricular diastole and atrial systole, when the tricuspid valve is open, the pressure measured in the right atrium reflects the right ventricular pressure. Thus, the CVP measured at the end of ventricular diastole can be used to monitor IV fluid administration, and to estimate the filling pressure or the preload of the right ventricle. CVP catheters are usually inserted percutaneously into a large central vein, such as the internal jugular, or peripherally through the medial basilic or lateral cephalic vein. Pressure measurements are usually performed during exhalation and when the patient is supine. The transducer is zeroed at the level of the right atrium. A normal value for CVP is 2 to 6 millimeters of mercury. The most common problems encountered with insertion of CVP catheters are pneumothorax, hemothorax, and vessel damage. Other potential complications include infection, thrombosis, and bleeding. Placement of the catheter usually is confirmed by radiography. Bedside catheterization of the right heart and pulmonary artery became possible when Swan and colleagues introduced a balloon-tipped, flow-directed catheter in the early 1970s. The balloon-tipped flow-directed catheter, also referred to as the Swan-Ganz catheter or pulmonary artery catheter, is a multiple lumen catheter constructed of radio-opaque polyvinyl chloride. The standard adult catheter is 110 centimeters in length and is available in 7 or 8 French sizes. Remember that the French size divided by pi or 3.14 equals the external diameter of the catheter in millimeters. Both adult and pediatric catheters are marked at 10 centimeter increments. As with the systemic arterial catheters, a pressurized flush solution must be run through the catheter at a rate of 1 to 5 mLs per hour, except when making pressure measurements, to prevent clot formation within the catheter's lumen. As you can see on the image of the right is a Swan-Ganz catheter. This balloon-tip flow-directed right-sided heart catheter showing many of the features that are typically available on the pulmonary artery catheters. Distal lumen opens into the pulmonary artery. Distal or dual lumen catheters must have one lumen that connects to a balloon located near the tip of the catheter and a second lumen that runs the length of the catheter, terminating at a port at the distal end of the catheter. Triple lumen catheters have an additional proximal port that terminates approximately 30 centimeters from the tip of the catheter or at the level of the right atrium. The third lumen can be used to measure right atrial pressures or for administering intravenous medications. As with the CVP catheters, PA catheters can be inserted using a percutaneous approach or via surgical cut-down technique. The subclavian, internal jugular, external jugular, femoral, or antecubital veins are usually used for percutaneous insertion. Surgical cut-down is often necessary when the subclavian or antecubital veins are used. The clinician must consider a number of potential complications when choosing an insertion site, including pneumothorax, arterial lacerations, venous thrombosis or phlebitis, and air embolism. Positioning the catheter can be accomplished by fluoroscopy or by monitoring the pressure tracings generated as the catheter is slowly advanced into the right heart and pulmonary artery. Fluoroscopy typically is reserved for the catheterization laboratory, whereas continuous pressure monitoring with electrocardiography is routinely used in the critical care setting. This image shows a series of tracings obtained during PA catheter placement. The catheter is introduced into the peripheral vein and slowly advanced until it enters the intrathoracic vessels, either superior or inferior vena cava. When the catheter enters into the intrathoracic vessels, venous pulse waveforms with characteristic respiratory fluctuations are recorded. If these respiratory fluctuations may indicate that the stopcock is closed between the catheter and the pressure transducer, can also occur if the catheter is kinked or a blood clot or air is present in the tubing. Once the catheter enters the intrathoracic vessels, the balloon is inflated with air so that it can be flow directed by the blood through the right atrium and right ventricle into the pulmonary artery. The catheter is slowly advanced until it wedges in a small pulmonary artery. The wedge position can be easily identified because the pulmonary artery occlusion pressure, or PAOP, is characteristically lower than or equal to the pulmonary artery diastolic pressure. An overdamped tracing usually indicates a mechanical problem, such as the presence of an air bubble in the catheter tubing or the protrusion of the balloon over the tip of the catheter. The mean PAOP may exceed the PA diastolic pressure in patients with mitral stenosis or mitral regurgitation. The PAOP can be identified by another means. When the catheter occludes a small pulmonary artery, a continuous column of blood equilibrates between the left atrium and the distal port of the catheter, and the pressure tracings will register a left atrial waveform. The catheter must be wedged in a zone 3 position in the lung to reflect the pulmonary venous pressure accurately. If the catheter is positioned in zone 1 or zone 2, the alveolar pressure will exceed the pulmonary venous pressure and cause the vessels distal to the balloon to collapse. The intravascular pressure reading will reflect the intra-alveolar pressure rather than the pressure transmitted from the left atrium. This problem is accentuated by the application of positive end expiratory pressure, or PEEP, during mechanical ventilation, or by hemorrhage when the pulmonary venous pressure is reduced. The PA catheter must be wedged in zone 3 position in the lung to reflect the pulmonary venous pressure accurately. This table lists the most common complications associated with right heart catheterization using a balloon-tipped flow-directed catheter. Ventricular arrhythmias are fairly common during catheter insertion and often are self-limiting. Electrolyte disturbances, hypoxemia, and acidosis increase the risk of developing ventricular ectopy. Careful monitoring of the patient's electrocardiogram during catheter placement can alert the clinician of the development of arrhythmias and reduce chances of provoking a potentially lethal complication such as ventricular tachycardia and fibrillation. Accurate interpretation of hemodynamic data requires a working knowledge of cardiovascular physiology. The hemodynamic profile ultimately focuses on those factors that influence cardiac output, namely heart rate, preload, contractility, and afterload. In this section, we will provide an overview of basic measurements and derived variables used in a standard hemodynamic profile. First is the heart rate. The resting heart rate of a healthy adult is typically 60 to 100 beats per minute. The heart rates for neonates and infants are considerably higher. Although the resting heart rates for toddlers and adolescents are higher than for adult subjects, the difference is minimal by the end of the first decade of life. Bradycardia, or heart rates less than 60 beats per minute, is associated with increases in parasympathetic tone or decreases in sympathetic tone. Tachycardia, or heart rates greater than 100 beats per minute, is associated with increases in sympathetic tone or decreases in parasympathetic tone. The typical adult can maintain an adequate cardiac output at heart rates of 40 to 50 beats per minute as long as stroke volume increases proportionally. An example, our well-trained athletes are good examples of this concept. Cardiac output will increase the heart rates of about 200 to 220 beats per minute, assuming that the patient responds normally to sympathoadrenal stimulation. Heart rates above 220 beats per minute cause a decrease in cardiac output because diastolic filling time is reduced. Systemic arterial pressures are typical systemic arterial pressure tracings, and these tracings, or the normal systemic arterial pressure for adult subjects range from 90 to 140 millimeters of mercury on the systolic side and 60 to 90 millimeters of mercury on the diastolic side, with a normal mean arterial pressure of 70 to 100 millimeters of mercury. It is generally accepted that the systemic hypertension exists when the systolic arterial pressure is greater than 140 millimeters of mercury, and the diastolic pressure is greater than 90 millimeters of mercury. Systemic hypotension is associated with systolic pressures less than 100 millimeters of mercury and diastolic pressures less than 60 millimeters of mercury. It is important to recognize that systemic arterial pressures in children, particularly very young children, are significantly different from adult subjects. Although it may not be apparent, the systemic arterial pressure waveform will change in shape and magnitude depending on the site of the measurement and the age of the patient. For example, systolic pressure increases as the site of measurement moves away from the heart. This effect is more obvious in young patients than in older adults. Diastolic pressure, on the other hand, is affected by vascular tone. An increase in diastolic pressure is associated with vasoconstriction, whereas a decrease in diastolic pressure is associated with vasodilation. Pulse pressure, which is the difference between the systolic and diastolic pressures, is influenced primarily by the stroke volume and the arterial compliance. A wide pulse pressure is associated with an increased stroke volume and a decreased arterial compliance. A narrow pulse pressure is associated with a decreased stroke volume and an increased arterial compliance. Proper positioning of the balloon flotation catheter allows for continuous monitoring of right atrial pressures and pulmonary artery pressures and intermittent measurements of the pulmonary artery occlusion pressure. The right atrial pressure can be continuously monitored through the proximal lumen of a pulmonary artery catheter or through the CVP line. PA pressures can be monitored continuously through the distal lumen of a PA catheter. Left atrial and ventricular pressures can be measured intermittently during PAOP determinations. PAOP determinations represent retrograde pressure measurements that are obtained by inflating the balloon of the pulmonary artery catheter until it occludes a small pulmonary artery and wedges to block blood flow past the catheter tip. As mentioned previously, PAOP measured at the end of ventricular diastole reflects left ventricular and diastolic pressures because the mitral valve is open and the pressure in the left ventricle is transmitted backwards into the pulmonary circulation to the catheter tip. Direct measurements of right ventricular pressures are usually only obtained during insertion of the catheter. Identification of the right ventricular pressure waveform during continuous monitoring indicates that the catheter has slipped into the right ventricle. It should be repositioned by reinflating the balloon and allowing the blood flow to carry the catheter back into the pulmonary artery. The balloon should be deflated once the catheter is repositioned in the pulmonary artery. As mentioned, the balloon should be inflated for short periods of time when measuring PAOP. The right atrial pressures and left atrial pressures are reported as mean values rather than as systolic and diastolic values. The RAP, more specifically CVP, normally ranges from 2 to 6 millimeters of mercury. The left atrial pressure, as estimated from the pulmonary artery occlusion pressure, ranges from 5 to 12 millimeters of mercury. CVP and PAOP measurements commonly are used to determine overall fluid balance. A low CVP or PAOP suggests hypovolemia, whereas elevation of either of these pressures indicates hypervolemia or ventricular failure. The pulmonary artery occlusion pressure also plays an important role in assessment of pulmonary hydrostatic pressure in the formation of pulmonary edema. PAOP can help distinguish cardiogenic pulmonary edema, or increased pulmonary capillary hydrostatic pressure, from non-cardiogenic pulmonary edema, or normal pulmonary capillary hydrostatic pressure, as occurs in ARDS. For example, the finding of bilateral infiltrates on chest radiographs coupled with a PaOP of greater than 25 millimeters of mercury suggests the presence of cardiogenic pulmonary edema resulting from left-sided heart failure. This is in contrast to a finding of bilateral infiltrates on chest radiography with a normal PaOP, which would indicate the presence of non-cardiogenic pulmonary edema resulting from damage to the alveolar capillary membrane and suggests the presence of ARDS. The pulmonary artery pressure waveform resembles the systemic arterial waveform previously discussed. However, the PA systolic and diastolic pressures are considerably lower than the systemic pressures. As does the systemic arterial pressure tracing, the PA pressure tracing shows a rapid rise to peak pressure during systole, followed by a gradual tapering to the dicrotic notch. The baseline of the PA pressure tracings shows characteristic respiratory fluctuations arising from changes in the intrathoracic pressure. With spontaneous breathing, the intrapleural pressure decreases during inspiration, causing the PA wave pattern to descend. Conversely, with spontaneous expiration, intrapleural pressure increases and the wave rises. With positive pressure breathing, the curve rises as intrapleural pressures become positive and falls during the expiratory phase. The intrapleural pressure is the same for spontaneous or negative pressure and positive pressure breathing at the end of expiration, as long as PEEP is not used. For this reason, PA pressure by convention is measured at end expiration. The mode of mechanical ventilation used can also significantly affect measured hemodynamic parameters. It has been shown that the lower mean inspiratory pressures present with IMV and PSV minimize the hemodynamic effects of positive intrathoracic pressure and help maintain right heart preload and cardiac output. Pressure-controlled ventilation has about the same effect on hemodynamic values as does volume-controlled ventilation. However, pressure-controlled inverse ratio ventilation decreases cardiac index and thus oxygen delivery. The use of PEEP, either applied or inadvertent, such as auto-PEEP, at levels greater than 15 centimeters of water pressure can produce erroneously elevated pressure readings. The pressure in the thoracic circulation will rise when using PEEP therapy because of compression of the vessels by the increased lung volumes. PaOP, which reflects preload of the left side of the heart, is a valuable parameter to monitor when performing an optimum PEEP study. If PaOP increases significantly during the study, it could indicate overinflation of the alveoli. Actual blood flow through the vessels may not be affected because the transmural pressure, or the pressure difference between inside and outside the vessel, may not have actually decreased. Pathologic conditions and pharmacologic interventions can significantly affect PA pressure. Pulmonary hypertension, pulmonary embolus, and congestive heart failure are associated with increased PVR, which in turn leads to increased PA systolic pressures. In contrast, inhaled nitric oxide, which selectively dilates the pulmonary vasculature, decreases PVR and PA systolic pressures. Cardiac output is the volume of blood that is pumped by the heart per minute, and it is usually expressed in liters per minute or millimeters per minute. Cardiac output normally ranges from 4 to 8 liters per minute. It can be calculated by multiplying the heart rate by the stroke volume. The stroke volume is the volume of blood pumped by the heart per beat. It can be expressed in liters per beat or milliliters per beat. In many cases, the cardiac output and the stroke volume may be reported relative to the person's body surface area, which can be easily obtained using a Dubois chart like the one that could be found in your textbook. This indexing technique allows the clinician to compare an individual's cardiac output or stroke output with that of normal healthy individuals of the same weight and height. Cardiac index is calculated by dividing the cardiac output by the body surface area, or similarly, stroke volume index is calculated by dividing stroke volume by body surface area. A normal cardiac index for an adult is about 2.5 to 4.0 liters per minute per meter squared. The stroke index normally ranges from 35 to 55 milliliters per beat per meter squared. Decreases in either heart rate or stroke volume can cause reductions in cardiac output. Decreases in the effective ventricular rate are usually associated with the following: a decrease in sympathetic tone, as occurs with the use of beta-adrenergic blockade, or an increase in parasympathetic tone and the presence of various types of bradyarrhythmias. Decreases in stroke volume are associated with reduced preload or contractility of the heart, or with an abnormally high afterload. Note that tachyarrhythmias associated with very high heart rates can lead to decreases in ventricular filling, which can ultimately result in reductions in cardiac output. In contrast, increases in cardiac output are associated with increases in heart rate or stroke volume. Increases in heart rate associated with either an increase in sympathetic tone or a decrease in parasympathetic tone will lead to an increased cardiac output. Increases in stroke volume are associated with increases in preload and contractility with reductions in afterload. Most experts agree that the gold standard for determining cardiac output involves direct measurements of oxygen consumption and arterial and mixed venous oxygen contents. Once these measurements are made, cardiac output can be calculated using the Fick principle. Oxygen consumption can be derived from measurements of the fractional concentration of inspired and expired oxygen and minute ventilation. If these measurements are not available, many clinicians use an oxygen consumption of 3.5 milliliters per kilo per minute as an estimate of the person's oxygen consumption. Calculation of oxygen content requires the measurement of oxygen partial pressures and saturation for oxygen of arterial and mixed venous blood. Arterial samples can be obtained from a peripheral artery. Mixed venous blood samples can only be obtained during right heart catheterization by withdrawing blood from the pulmonary artery. The oxygen saturation of arterial blood, or SaO2, is normally 98%, and the arterial oxygen content, or CaO2, of a normal healthy individual is approximately 20 volumes percent, or 200 mLs per liter of whole blood. The mixed venous oxygen saturation is normally about 75%, and the mixed venous oxygen content is about 15 volumes percent. If the oxygen consumption and cardiac output remain constant, then the difference between the arterial oxygen content and the mixed venous oxygen content also remain constant. Mixed venous oxygen values decline when arterial oxygenation is decreased. They also decrease when cardiac output is reduced. With a reduced cardiac output, more time is available for the extraction of oxygen from blood delivered to the tissues. Reductions in SpO2 are also associated with increases in metabolic rate in patients with limited cardiac output. Mixed venous oxygen values can be higher than normal in patients with histotoxic hypoxia, such as cyanide poisoning, and in situations where intrapulmonary shunting occurs, such as ventilation perfusion mismatching. With recent advances in fiber optic reflectance oximetry, continuous recordings of SpO2 can be obtained. Reflectance oximetry technology has been incorporated into specialized balloon flotation catheters that are used for right heart catheterization. Although the potential for this type of monitoring is promising, more studies are required to delineate more clearly the indications for its use in critical care. Oxygen delivery, or DO2, is the product of cardiac output and the arterial oxygen content. It represents the total amount of oxygen that is carried in the blood to the tissues each minute. Under normal circumstances, DO2 is approximately 1,000 mLs per minute, or about 550 to 650 mLs per minute per meter squared. DO2 is increased in situations where cardiac output or arterial oxygen content is elevated. A reduced DO2 indicates a decrease in cardiac output or arterial oxygen content. For example, DO2 is increased in hyperdynamic states, such as increased cardiac output, as in septic shock. Conversely, DO2 is decreased following hemorrhage, where there is a decrease in arterial oxygen content. A shunt is defined as that portion of the cardiac output that does not participate in gas exchange with alveolar air. Shunts are usually identified as anatomical shunts, intrapulmonary shunts, and physiological shunts, with the latter being the sum of anatomical and intrapulmonary shunts. Normal anatomical shunts exist because venous blood that would ideally return to the right side of the heart drains into vessels served by the left side of the heart. This venous admixture includes deoxygenated blood from bronchial veins, pleural veins, and Thebesian veins, and typically only represents about 2% to 3% of the normal cardiac output. Abnormal anatomic shunts can occur when blood is allowed to bypass the pulmonary circulation and enter directly into the left atrium or left ventricle, as occurs with atrial and ventricular septal wall defects. Intrapulmonary shunts occur when blood passes through the pulmonary capillaries that are not ventilated. Shunt-like states can exist in either poorly ventilated alveolar units that are well perfused or in alveolar capillary units where oxygen diffusion is impaired. Intrapulmonary shunts can be caused by disorders such as atelectasis, pulmonary edema, pneumonia, pneumothorax, complete airway obstruction, consolidation of the lung, ARDS, and on rare occasions by arterial to venous fistulas. Vascular resistance represents the impedance or opposition to blood flow offered by the systemic and pulmonary vascular beds, and it influences the force that the ventricular muscle must generate during cardiac contractions. The two most important factors that influence vascular resistance are the caliber of the blood vessels and the viscosity of the blood. The SVR is therefore increased in left ventricular failure and hypovolemia arising from vasoconstriction caused by stimulation of the baroreceptor reflex. The SVR may also be increased if blood viscosity increases, as occurs in polycythemia. SVR decreases during systemic vasodilation, such as occurs with moderate hypoxemia or following the administration of systemic vasodilators, such as nitroglycerin or hydralazine. The PVR increases during periods of alveolar hypoxia or in cases where high intra-alveolar pressures are generated, such as during positive pressure ventilation. A low cardiac output can increase PVR by causing the recruitment of pulmonary vessels. PVR is reduced by the administration of pulmonary vasodilator drugs. The ejection fraction is a derived variable that provides an estimate of ventricular contractility. It is calculated by dividing the stroke volume by the end diastolic volume. The ejection fraction shows positive correlation with cardiac index in most cases, and it is a valuable measurement in the prognosis of heart failure. Note that the correlation between ejection fraction and cardiac index may be inaccurate in cases of mitral regurgitation. Ejection fraction values of 0.5 to 0.7 are considered normal for healthy adults. Ejection fraction values lower than 0.3 are associated with compromised cardiovascular function and imminent heart failure. In physics, work is defined as the product of a force acting on an object to move it at a certain distance. In calculations of cardiac work, or more specifically stroke work, the pressure generated by the heart during a ventricular contraction is used to quantify the amount of force developed. And the stroke volume represents the distance portion of the equation. In this table, you would see there's some of the hemodynamic parameters that can be calculated. And here our hemodynamic parameters can be measured directly. In this table, you will see hemodynamic changes commonly seen in respiratory distress. The up arrow represents increase, down arrows decrease. You have unchanged, and this will tell you the differences in terms of hemodynamic changes and any of the values that will represent either a neutral or no change or an increase or decrease in the hemodynamic indices that would fluctuate or change with a respiratory or a particular respiratory disease. In summary, hemodynamic monitoring can provide a window to observe the effects of various physiological and pharmacologic interventions on cardiovascular function. The effective use of hemodynamic monitoring requires knowledge of the basic principles of cardiovascular physiology, as well as an understanding of the physical and technical factors that can influence the measurement conditions. Cardiac output is primarily influenced by heart rate and ventricular preload, contractility, and afterload. CVP and PaOP can be used to assess right and left ventricular preload, respectively. Ejection fraction is a valuable clinical indicator of ventricular contractility. The systemic vascular resistance and pulmonary vascular resistance are used clinically to describe the afterload to the left and right ventricles, respectively. Positioning of a pulmonary artery catheter can be accomplished by fluoroscopy or by monitoring the pressure tracings generated as the catheter is advanced into the right heart and pulmonary artery. Accurate measurements of the pulmonary artery occlusion pressure requires wedging of the pulmonary artery catheter in the zone 3 portion of the pulmonary vasculature. Pulse pressure is the difference between the systolic and diastolic pressure, and it is influenced by the stroke volume and arterial compliance. Cardiac index and stroke index allow the clinician to compare an individual's cardiac output and stroke output with those of healthy individuals of the same weight and height. Cardiac index and ejection fraction are important variables used in determining the prognosis of heart failure. Cardiac work is primarily influenced by stroke volume and systolic arterial pressures. Calculation of oxygen content requires the measurement of oxygen partial pressures and saturations in arterial and mixed venous blood. Oxygen delivery to the tissues is increased in situations where the cardiac output and arterial oxygen content are elevated. It typically is decreased when either of these variables is reduced. Systemic vascular resistance and pulmonary vascular resistance represent the impedance or opposition to blood flow offered by the systemic and pulmonary vascular beds, respectively. Vascular resistance influences the force that the ventricular muscle must generate during cardiac contractions. And cardiac work provides an estimate of the amount of force that must be generated by the ventricles to achieve a given stroke output.